You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for February 28th, 2025. This week, the debate over operating on asymptomatic patients with aortic stenosis, the move to composite endpoints in cardiac trials, IFR versus FFR, and high-frequency low-tidal volume ventilation for AF ablation. First is the major topic of aortic valve intervention for patients with asymptomatic aortic stenosis. JAMA Cardiology has published a widely circulated editorial this week from three leaders in the field of aortic stenosis therapy. The second author was Eugene Brunwald himself. The title of their opinion piece was Aortic Valve Replacement for Asymptomatic Severe Aortic Stenosis, The Time Has Come. Now, from that title, you can gather that they are advocating for treating patients with asymptomatic AS. And this would be a big change because for my entire career, we have recommended AV interventions when patients with severe AS become symptomatic. The triad of symptoms of AS, as you know, include angina, fainting, and heart failure symptoms like dyspnea on exertion. The three key opinion leaders' argument cited three RCTs comparing either surgical AVR or transcatheter aortic valve replacement TAVR, or either versus clinical surveillance. Now, before I tell you why I disagree with their opinion on changing practice patterns, I want to set out how big a deal this is and how it would lead to a serious expansion of the number of TAVR procedures. I found a paper that I'll link to on trends in aortic valve interventions, and there has been a massive shift from surgical aortic valve replacement, SAVR, to TAVR, especially in patients between ages 65 and 80. For instance, in this group, in the last year of the study, 2022, 14% of aortic valve interventions were SAVR and 86% were TAVR. Now, if we shift to asymptomatic patients, there will be, of course, even more patients having TAVR. Notable in this case were that 2 of the 3 KOL authors declared relationship with makers of TAVR valves. Now, one more thing before I get into the critical appraisal of the 3 trials is the difficulty in measuring severe AS. My friend and former partner and echo expert, Anthony Pearson, emailed me about this challenge, and he wrote that the aortic valve area should be the measurement utilized to determine the severity of AS. Gradients are too dependent on flow. And it has only been in the last 15 years or so that the arbitrary definition of severe AS has increased from 0.75 centimeters squared to 1.0 centimeters squared. He wrote, using the 0.75 centimeters squares as my criteria for AS, I have had no asymptomatic patients die prior to their aortic valve intervention. But with less than 1.0 centimeters squared as the cutoff, a very large number of AS cases fall barely into the severe range, and this is a measurement that requires meticulous attention to optimizing recording. Dr. Pearson writes that he's remeasured hundreds of such cases resulting in moderate AS and saving the patients from unnecessarily premature aortic valve intervention. Echo reading, Dr. Pearson concludes, requires meticulous attention to detail as well as a neutral mindset, and I concur with this. I think people have this impression that echo reading is like interpreting a lab value. It is not. It is a lot more subjective than people think or know. Now let's get to the critical appraisal. I covered the early TAVR trial on the November 8th This Week in Cardiology podcast, and we'll briefly go over it now. That trial compared clinical surveillance to early TAVR in 900 patients with asymptomatic severe AS. And my main issue with that came in the choice of the primary endpoint, which was a composite of death, stroke, and, quote, unplanned hospitalizations for cardiac causes. Top-line results of early TAVR were positive. It reported a statistically significant 50% reduction in the primary endpoint with the early TAVR group. The sole driver of the primary endpoint was unplanned hospitalization, mostly for symptoms of AS. Death and strokes were not different. And of course, the fatal flaw of this trial was that it was unblinded, so patients in the surveillance arm knew they had severe AS but were not treated, whereas the other group got, quote, fixed. It's a classic problem with a phenomenon called faith healing and subtraction anxiety. So I put very low early weight on early TAVR, and I'll link to the Christopher Raj Kumar piece on faith healing and subtraction anxiety, and it is a classic piece. The key opinion leaders also cited 2 other trials in support of their call for early intervention. The second trial was called the EVOLVE trial. It had 224 patients with asymptomatic severe AS and evidence of LGE in the left ventricle. This was a UK-Australian trial that compared clinical surveillance to early aortic valve intervention that could be either TAVR or SAVR, and it was mostly surgical aortic valve replacement. A primary outcome of death or unplanned AS-related hospital admission occurred in 18% of the early group versus 23% of the clinical surveillance arm. That 21% relative risk reduction did not meet statistical significance, did not meet hazard ratio 0.79, confidence interval 0.44 to 1.43. The death rates were similar in both arms. EVOLVE was a non-significant trial. Now, the KOLs, however, called it underpowered and blamed the fact that the diagnosis to intervention time in the active arm of the EVOLVE trial was as long as 5 months. The third trial they cited in their opinion piece was called AVATAR, and it was a small trial of 157 asymptomatic patients randomized 1-to-1 to surgical AVR or clinical surveillance, and AVATAR was positive, a 54% relative risk reduction in death, MI, stroke, or unplanned hospitalization for heart failure. While all-cause death was also significantly lower in the SAVR arm, curiously, cardiac death rates were the same. Now, the AVATAR authors were cautious in their conclusion, saying that this was preliminary evidence for early surgery. All right, my comments all together. In sum, the key opinion leaders urged more aggression in operating on patients who complain of nothing but have abnormal shadows on their ultrasound. One trial they cite is flawed because it is unblinded and driven by a bias-prone endpoint of unplanned hospitalizations. Another trial delivered non-significant results for its primary endpoint, and a third trial is small and considered preliminary. So I don't agree with this opinion, and from my perch here in private practice, I see a huge potential for overtreatment, especially using TAVR. Now, to those who I have not persuaded and think we should operate on asymptomatic patients, I will concede that there is a gray area here worth considering in this case. And that is a seemingly asymptomatic patient who has such slowly progressive aortic stenosis that he or she has adjusted their lifestyle to limit exertion so as to avoid dyspnea or dizziness from the low cardiac flow through the valve. These patients may be billed as asymptomatic, but they are not. And of course, here, a careful history and possibly a low-level exercise test may help tease out these symptoms. That said, patients who report normal functional capacity, patients who report being happy, and all they have is an abnormal ultrasound, I think can be followed, or as it is in this trial called clinically surveilled. All right, next topic is trial endpoints. Whenever I lecture on evidence-based medicine, one of the most common questions I get pertains to endpoints. That is, in the days of old, trials measured alive or dead. There was no adjudication, no bias, and the only decision the reader had to make was whether the difference in death rates was A, clinically significant, and B, due to the treatment effect and not statistical noise. Newer trials, however, have become much harder to interpret, because trialists have added composite endpoints of many different surrogate outcomes. And you've heard me talk about it, things like death due to cardiac causes, MI, stroke, angina, heart failure hospitalizations, urgent revascularization. JAMA Internal Medicine has published a study from a group at Columbia University looking at outcomes of major trials in atherosclerotic disease. This was a descriptive study where they focused on the heterogeneity of original endpoints of trials. Like many of these studies of studies, they selected trials from major journals, the New England, Lancet, JAMA, European Heart, Circulation, and JACC. And they looked at the years 2019 to 2023, which is great because these are recent trials. They looked only at the primary analysis of the trials, and they included 50 RCTs. Nearly all, 49 of 50, used composite endpoints. That's a striking statistic right there. Now, the most common composite endpoint was the 3-point MACE of MI, stroke, and death. MACE stands for Major Adverse Cardiac Events. But this was hardly a majority of trials. Only 14 of 50 trials, or 28%, used this classic 3-point MACE. The remaining 36, or 72% of trials included, and sit down for this because it is the key finding of the study, 29 different endpoint combinations. This is crazy. But perhaps even crazier was that the published and original endpoints were different in half the trials. In a third of trials, components of the original primary endpoint were edited after enrollment of patients, but not all of the trials reported these changes. The most common rationale for changing endpoints was to add power, in other words, to accrue more events. In 8 of the 50 trials, or 16%, the initial clinicaltrials.gov entry reported an undefined original endpoint, for example, quote, just cardiovascular disease, or simply MACE. The authors concluded that there is a bunch of heterogeneity in endpoints in atherosclerotic CVD RCTs. This, they write, quote, may complicate comparing results of different studies of interventions. I'd say that's a very obvious statement. And they add, rightly, I think, that modifying endpoints between the study initiation and publication compromise the trial's scientific validity. And obviously, this is also true. And finally, they suggest that regulators and journal editors should require that atherosclerotic cardiovascular disease RCTs use uniform endpoints, such as the 3-point MACE. I could not agree more with all of this. The main teaching point from this well-thought-out investigation is that it actually chronicles what we know, that composite endpoints vary a bunch and can even change over the course of the trial. And the reason for this variability is partly a result of our field's success. I mean, take heart failure, for instance. It's going to be really hard to extend life any further than has already been achieved with the 4 classes of GDMT, and it's the same with stable coronary disease and a lot of cardiac conditions. So what do trialists do? They add more surrogate endpoints to the composite. That increases the number of event rates and it adds power. But, these are huge buts. The users of this evidence, you and I, now have to fight through the potential hype of a positive trial. But it's driven by one of the softer surrogate endpoints. This directly bears on the clinical significance of the finding. Now, a word on surrogate endpoints. These can be reasonable, but increasingly, with technology, they can mean less and less than they did in the past. Take MI, for instance. Many composite endpoints include MI, and an MI can be a great thing to avoid. But the problem with MI as a surrogate is that it's getting easier and easier to diagnose an MI. For instance, back in 2021, David Brown, when he was in St. Louis, led a huge meta-analysis of 144 cardiovascular trials that included more than 1 million patients randomized. And they assessed the degree to which a non-fatal MI met the threshold for surrogacy, which required 3 things. To be a surrogate, you have to be biologically plausible, you have to have observational studies showing a constant association between the surrogate and the endpoint, and the finding that the reduction of the surrogate also reduces the ultimate endpoint of interest, like, say, CV death or all-cause death. But Brown and his team found that overall, non-fatal MI was not a surrogate for all-cause death or CV death. This makes total sense, right? Because 30 years ago, an MI was diagnosed with a CK elevation and ECG changes, and an MI was darn serious. And it still can be darn serious, but more recently, it's much easier to make a diagnosis MI with, say, a high-sensitivity troponin and some non-specific SDT wave changes on an ECG. Overall, the JAMA internal medicine analysis is sobering and it's worth you looking at. Composite endpoints are all over the place these days and consist of quite dubious surrogate markers, which means, sadly, that many of our positive contemporary trials represent very small incremental gains, and the onus is on us to be the neutral, skeptical, but not cynical users of this evidence. All right, next topic is a brand new debate that I didn't know of. This is IFR versus FFR, and it's actually a debate between RCTs and observational data, and I want to tell you what I learned about it this week. I did not know there was a debate in interventional cardiology regarding the use of these two techniques to assess functional stenosis of coronary lesions. Of course, the old technique was a lot like echo reading. The interventional cardiologist would eyeball the angiogram and say it was 70% or 80% or 90%. And it was like judges who give harsher sentences before lunch. There was an utter lack of reproducibility in this kind of angiographic visual assessment. Well, then came two techniques to assess coronary physiology. Fractional flow reserve uses adenosine to increase flow, and the pressure gradient across the lesion is assessed during maximal vasodilatation, and anything below a ratio of 0.80 is considered significant, and don't get me started on where 0.80 comes from. IFR, on the other hand, is adenosine-free, and it's assessed during diastole. It's simpler, and it's easier to do, and it is a ratio. And, as it turns out, two RCTs have directly compared the strategies for stable patients who are having angiography and considered for revascularization. One of these trials was called the Define Flare trial, which included 2,500 patients and was originally published in the New England Journal of Medicine. At 1 year, there was no difference in the primary outcome of death, MI, or unplanned revascularization. However, at 5 years, get this, there is now an 18% higher rate of the primary outcome in the IFR arm. The hazard ratio included 0.99 to 1.42, and the p-value was 0.06, so technically this wasn't statistically significant. But the bigger issue with Define Flare 5 years came when looking at all-cause death and CV death, which was 56% and 2x higher in the IFR group, respectively. Why is that? The weird thing was that MI and revascularization rates were not all different. And in patients who had their stent deferred because of the measure, there was no difference. All of the increased risk in the IFR arm was in patients who had the PCI done. And all of this is strange. It's hard to explain. The second trial comparing IFR and FFR was called Sweetheart IFR. Here, 2,000 patients were randomized, and there was no significant difference at 1 year. It was the same primary endpoint of death, MI, and revascularization. At 5 years, the results were not significantly different for IFR versus FFR, though numerically there were more MACE events, and the rate of death was 9.4 versus 7.9. That hazard ratio of death was 1.20, but the confidence intervals showed non-significance because they went from 0.89 to 1.62. Now, both of these trials had similar follow-ups and similar procedures and identical endpoints, so they lended themselves to a meta-analysis. And one of these meta-analyses was published in 2023 in European Heart Journal. The first author's name is difficult to pronounce, so I apologize in advance. It is Ashkan Eftekari, and they found an 18% higher rate of MACE with a hazard ratio 1.18, a confidence interval 1.04 to 1.34, and, get this, a 34% higher rate of all-cause death. Here the hazard ratio is 1.34, confidence intervals 1.08 to 1.67 in the IFR arm. But, similar to both trials, there was no difference in MI or unplanned revascularization. Now, I bring this up because earlier this week, JACC Interventions Journal published yet another study in this IFR versus FFR debate. It was a large observational study. So before I even tell you about it, we have two RCTs and a meta-analysis of RCTs of about 4,500 patients. The observational study, first author Matthias Goldberg, assessed 5-year outcomes of IFR versus FFR from the Sweetheart Registry. This included about 43,000 patients who had either IFR or FFR. Now, of course, this was not randomized groups. So the authors did a 2-to-1 propensity score matching in about half the patients, leaving a group of about 16 patients who had FFR and 8,500 who had IFR as the two comparison groups. They also did a secondary analysis wherein they compared the groups without matching. And this observational real-world study found no differences in MACE death, CV death, MI, or unplanned revascularization in the main propensity-matched group with IFR versus FFR. Of note, the unadjusted risk for all-cause mortality in the unmatched cohort was increased with IFR like it was in the trials, a 12% increase, even as the risk for MACE was reduced. This, the authors argue, is likely because operators tend to do IFR on older, sicker patients. Okay, now we have a problem, don't we? We have RCT data which show a clear signal for worse outcomes with IFR. The death signal in the meta-analysis is significant, but it's hard to explain because the signal was not seen in the deferred PCI cohort of the DEFINE trial. The overlap between IFR and FFR is fairly high. About 80% of the time there's concordant results, but about 1 in 5 patients may get discordant results with the two techniques, meaning one is positive and the other negative, which may lead to different approaches, PCI or no PCI, for instance. The tension, of course, is that real-world observational data showed no differences. And the problem, of course, is the same with all observational comparisons, isn't it? A doctor chose to do one of the other techniques based on their experience with the patient. And while the authors of the observational study did matching, a lot of matching, you can only match based on items on the spreadsheet. In the unadjusted analysis, death was higher. It went away with adjusting, but what does that mean? I don't know, I'm asking. Now, two editorialists in JACC Interventions accompanying the observational study put their chips down on there being no difference in outcomes with the techniques. And they lean on the observational study, citing that its size and its real-world origin and its strong attempts at adjustment. They also say the death signal in the meta-analysis is likely noise, as the number of deaths were small and there was no signal of other outcomes that could have led to higher death rates. And I find this whole thing a fascinating exercise in evidence-based medicine because as an outside observer, it is really hard to say. I guess I lean like 51-49 or 55-45, but not strongly toward there being no true harm signal with IFR. And I guess I would also suggest another line of evidence, and I could be wrong about this, but in all the IFR versus FFR studies, IFR led to more deferrals of PCI. And we know from the FAME-1 trial that fewer stents led to better outcomes. And we also know from every single chronic CAD trial that's ever been done that revascularization does not improve outcomes over meds. So to me, it is hard to implicate a measure that reduces PCI as harmful since PCI is so neutral in chronic coronary disease. Now, sadly, there are no more planned RCTs of IFR and FFR. So this may have to be one of medicine cardiology's mysteries. By all means, if you are an interventional cardiologist or a methodologist and you've looked at this debate and have an opinion that's different from mine, or you have a solution to going whether we should go with the observational data or the RCTs, please let me know in the comments or email me. Let me know, and we'll talk more about it next week. All right, final topic today is a brief one, and it has to do with the type of anesthesia we use for AF ablation. It's high-frequency, low-tidal-volume ventilation is the active arm. So speaking of non-random comparisons, a study in the journal Heart Rhythm compared two strategies of general anesthesia for the ablation of AFib. Now, I know this is a general cardiology podcast, so who cares about such a specific question? And I hear you. I highlight this study because it is a classic example of how not to study two treatment strategies. Now, consider this topic more a question about ways of knowing in medicine rather than an AF ablation specific question. Here is the background. In the prehistoric days of point-to-point RF ablation, we would make dots around the PVs to electrically isolate the muscle bundles within the veins. Each of these dots was a few millimeter burn, if you will. Now, I say prehistoric because most labs have gone to use these multi-pole PFA catheters, which ablate large swaths of atrial muscle rather than a single point lesion. One of the challenges of point-to-point RF ablation was that each lesion had to be perfect, because if it was not perfectly transmural, surviving myocardial cells would lead to pulmonary vein reconnection, and there would be recurrence of AFib days to weeks to months later. Now, one of the proposed ways to get perfect point RF lesions was to minimize chest movement during respiration. In the very early days of AF ablation, we struggled with this a lot because we used conscious sedation and patients would take these huge breaths. Well, then we moved to general anesthesia where breaths were controlled. But, of course, like there always is in medicine, there's a group of maximalists who proposed even better general anesthesia wherein ventilation was maintained with a very low tidal volume and a high respiratory rate. You get the same respiration, but you just get it with less chest movement. The extreme example of this would be called high-frequency jet ventilation, and the name is not important. It's simply ventilation with very low chest movement and a higher respiratory rate. The idea being you can deliver better quality RF point lesions and you'll get better suppression of AF, and it's a totally reasonable question. And I truly hope that This Week in Cardiology listeners would know how to answer this question, right? You would say tens of thousands, hundreds of thousands of AF ablations happen all the time. All we have to do is randomize a fraction of these cases to low-volume, high-frequency ventilation and the other to standard ventilation and measure outcomes. It's like the easiest trial ever. Well, that is not what a group of high-frequency, low-volume proponents have done. Instead, they took 210 patients who had ablation. They looked back and compared results of those who had the high-frequency, low-tidal-volume ventilation versus standard ventilations. Now, these study patients were part of a registry called Real AF, but giving it a name doesn't make it any less non-random. All patients had first AF ablation and posterior wall isolation, and all these patients had persistent AFib. And they found that patients who had the special ventilation had a shorter procedure time and less AF in follow-up, a lot less. It's like a 43% relative risk reduction, 13% absolute reduction. And in the high-frequency, low-tidal-volume ablation arm, 82% of patients with persistent AFib were free of AFib at 1 year, which is crazy high. And the authors who were proponents of this strategy spent many words in the discussion explaining exactly why the high-frequency, low-tidal-volume approach is better. They do mention in their last paragraph that this was a non-random comparison, and there could be selection bias, but conclude that the high-frequency, low-tidal-volume ventilation was associated with better outcomes, period. End of story. No caveats, no mention that this is hypothesis generating and should be confirmed in an RCT. So, my friends, my comments are that this is bad on multiple levels. First, the special ventilation, high-frequency, low-tidal volume requires more work. It's a different kind of anesthesia. They found no adverse events in this study of only 200 patients, but a lot of anesthesia in the community as delivered by non-doctors of varying and often low experience. Without randomization, we don't know whether the better results are driven by the different anesthesia or just patient selection or even performance bias of the doctor. The latter being that docs who have a patient on high-frequency, low-tidal-volume ventilation might just take better care to do better ablation, because it's really a patient's issue. You just go slow and make better RF lesions. Another problem is that they screened more than 500 patients and excluded 225 patients because they did not have 1 year follow-up, which means you have a selection bias because there's a different sort of patients who complete their 1 year follow-up. And yet another problem is you have a massive reduction in AFib, like a 13% absolute risk reduction, but the p-value is only 0.012, which is not very low, and I think it speaks to the low numbers of patients and the fragility of this result. I also question the 82% AF-free result at 1 year for persistent AFib. This is higher than many other studies of ablation of persistent AFib. Again, this I don't see as nefarious, but rather just a selection bias wherein operators are picking the better patients to do this in. Now, clinically, I don't worry too much about the adoption of special anesthesia techniques because most labs have moved to PFA, and sadly, PFA is so easy, it's like a brain-dead procedure if ventilation doesn't matter. I highlight this study because it is an example of how not to answer a question in medicine. AF ablation, like left atrial appendage occlusion procedures, are done at such high volume. It would be very easy to simply randomize patients, and we would learn so much from this. Looking back at non-random groups and comparing outcomes is fraught. It's problematic. And to me, the results are more likely to be misleading than correct. I wish more of my colleagues resisted the urge to do these non-random retrospective comparisons. So that's it for this week in cardiology. I'm here in Salt Lake City, Utah for the Western AFib Symposium. Perhaps next week I'll have some news about anything I hear at Nasir Marouch's excellent AFib meeting. As always, I'm grateful that you listened to this podcast. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. Please, if you disagree with something I say, let me know. I always learn from the feedback. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.